Welcome everybody. We're not quite yet kicking off. We've got a few people joining in our waiting room as we get ready to kick off. We're going to be taking off at 8 o'clock sharp. So welcome, get settled, make sure you've got some refreshments and got yourselves on mute because we're about to take off into what's going to be, I think, a really enlightening webinar tonight around workforce and particularly the impact that COVID-19 has had on rural health workforce. Kicking over to 8 o'clock now. So formally kicking off tonight. Thank you all so much for joining, taking some time out in your precious evenings. We know many of you are healthcare workers on the coalface. We want to thank you for all the hard work that you're doing. And for many of our remote colleagues, they're working very long shifts and have been working consistently for significant periods of time without backup. It's part of the discussion we're going to have, but massive shout out to you guys as well. And thank you for all the hard work and the dedication that you're showing for the communities in which you work and care so much for. Kicking off tonight as well, I'm going to just acknowledge country now. I'd like to acknowledge the Indigenous owners of the lands on which we all meet and work, elders past, present and emerging, and particularly tonight acknowledging those remote Indigenous communities and the challenges that they're facing, and any Indigenous healthcare workers out there amongst us. A shout out to you as well and thank you for joining. Tonight we've got a really strong panel and you're in for some very interesting discussions, some pretty influential and powerful people from government through a number of different organisations that are all about workforce and supporting rural health. So tonight I've got, I'm John Hall, I'm the president of the Rural Doctors Association of Australia. Joining me is Richard Colbran, the CEO of New South Wales Rural Doctors Network. That's the New South Wales Rural Workforce Agency. We've got Frank Quinlan, the CEO of the RFDS. We've got Fay Holden, the Acting First Assistant Secretary in the Workforce Division of the Department of Health. And we've also got, rounding out the panel, Dr. George Cerchez from the Tasmanian Department of Health. Good evening to you all and thank you for coming. We really appreciate, again, you taking time out of your very busy schedules for yet another Zoom meeting. I'm going to give you a brief introduction into what we're about to talk about tonight. The Rural Doctors Association came out of the gate very early, flagging the concerns around health workforce in the context of a pandemic in Australia. Thankfully, we haven't seen the numbers spreading into rural and remote Australia as what were predicted initially. In the early days, there were significant fears around us losing health workforce and needing significant surge capacity in our rural and remote sites. Also issues around increasing capacity in retrieval services as we watched devastation play out across the globe in many large European and American countries, and particularly in the rural areas in those countries where we saw health services being overwhelmed. Obviously, the Australian government has responded well from a public health perspective, and the Australian community has banded together, and we've seen with the impact of our social distancing and quarantining and decreasing unnecessary travel measures, as I said, significantly lower numbers than what were predicted originally. We still, however, have significant concerns about health workforce across rural Australia, particularly as we face what could be a second and third wave of COVID-19. As we know, this is a highly infectious virus that will no doubt penetrate throughout Australia over time. And as we see social distancing measures relaxed, state and international borders open up, we are predicting increasing cases, and they no doubt will have an impact on our rural health workforce. Even with the impact of things like the COVID Safe app, there may be doctors that are taken out of practice because of delays while they're being tested, or in fact, more doctors taken out of practice and nurses and healthcare workers taken out of practice because of exposure or suspected exposure in testing. So we still think that there will be a need for a ready surge workforce, and we certainly think that there will be a need for increased retrieval capacity, which we are very happy that the government has committed to $52 million, and you'll hear more from the RFDS later about what they've done in terms of working with the government around increasing their workforce and also capacity for retrieval services. I'm going to kick off though by bringing a question to Frank from the RFDS about RDAA and ACRM's concerns. RDAA and ACRM, as you know, have collaborated on the COVID-19 rural and remote response. We've had significant amount of media and engagement with state and federal ministers. We've advocated strongly from the get-go around increased capacity for retrieval services, particularly around concerns that there may have been rural patients that were disadvantaged if they had to wait for prolonged periods in rural hospitals, particularly if they are critically unwell in areas where they've got limited access to critical care drugs, workforce and equipment like ventilators. Obviously, RFDS is a key component of the strategy for the Commonwealth. Can you outline some of the key actions the RFDS has put in place to be ready, or situations where you've already responded to communities in relation to COVID-19?
Yeah, sure. Thanks, John, and thanks for your invitation tonight. It's great to be here. I should begin by saying I didn't check the numbers before I came on, but I think we're in the order of having conducted about 270 or 280 COVID or highly suspected COVID-related transfers already since February. And like all of us, we've seen a steady ramping up of that patient transport with perhaps a slight drop-off recently. So it really has been affecting our organisations from the get-go, and really I'd say that there were two main things that arose out of that for us. One is that we did have a pretty rapid conversation with the Commonwealth. So primary evacuations and primary health clinics are funded out of a Commonwealth pool. We had a conversation with the Commonwealth very quickly, and I'm pleased that Fay Holden's online to hear me say that the Commonwealth are very cooperative in basically just freeing up our existing contract arrangements in order to allow pretty immediately the sort of flexibility that we were all anticipating we were going to need in relation to COVID. So that very first step made a big difference and set a bit of the agenda. We began to be locked out of communities for primary health activities for good reason. To protect communities, that meant some of our primary health activities were reduced, and we started to move those across as best we could onto a telehealth platform. So that was all done within the sort of existing resource envelope. And then along with others, as you say, John, we were advocating strongly around the concerns around moving folks out of remote communities in particular, partially because our core business is in acute evacuations, and we recognised fairly early on in the piece that there were likely to be some low acuity evacuations that would be required as part of this process, both in order to move people closer to the help that they might subsequently need, to remove contacts from communities, and to avoid the very highly stressful and dangerous ventilator-based sort of acute transfers. So that's happened. The Commonwealth did come to the table recently and gave us a very substantial grant that has allowed a wide range of readiness activities across all of our operations. As you say, principally around securing workforce, around implementing additional procedures that we've all been part of. We had modelled a potential increase in demand of between 5% and 30%, and the Commonwealth have come to the party to essentially underwrite that substantial increase in activity should it arise. Of course, we hope most of it does not arise. They've also come to the party in terms of addressing the overhead that is applied when we are required to deal with patients who have to be assumed to be COVID positive. that's had a big impact, like in so many of our operations, split teams, splitting clinical teams physically away from engineering teams and so forth to ensure the maximum protection. Like others, we've invested a lot in securing PPE supply chain and ensuring as an organisation, we're in fact 6 separate organisations. We've now secured a single national supply chain in order to ensure that we're able to provide PPE. So it's been a pretty comprehensive response, I think characterised by a sense of collaboration both across the Federation and with the Commonwealth Government, who are our principal funder. And like you, we've now moved from a mode that was anticipating the worst, anticipating essentially a system that could have been completely overrun, and we are now anticipating a rapid response to outbreaks and spot fires as and when we need to.
That's fantastic, and it's so good to hear and really reassuring for our members and the doctors on the ground to know that capacity was increased rapidly. Because, as you've said, it could have been significant disadvantage in our communities if that hadn't happened in a timely way. Can you tell us a bit about your the assets? Like, how have you increased the number of assets across the country for flying?
Yeah, look, a lot of the flying assets, we don't have any more planes. We have entered into the sort of conditional and provisional charter arrangements, of course, to ensure that there's enhanced capacity available. Some of the rate limiting factors, though, are around engineering and around pilot supply in the air fleet. So we have actually seen some pilots coming back from Qantas and other places who aren't flying at the moment. It would not be an atypical career path for a pilot to spend some time with the RFDS on their way to becoming a commercial pilot with Qantas. We're now seeing some of those pilots come back and renew their training and accreditation in our fleet, which is again very encouraging, and very encouraging to see organisations like Qantas taking collaborative steps to provide backup resource where that's available. As I said, initially that was in the context of anticipating a system that could have been overwhelmed. We're now much more confident that we're likely to just have to manage demand as it arises.
Thanks so much, Frank. Just to remind our audience tonight, if you want to send through questions, click on the Q&A icon on the bottom of your screen. It'll open a window allowing you to ask questions. We can see these questions as they pop up, and we'll try and ask the panelists in real time if you have questions of the panelists as we go through. Thanks again, Frank. Moving on now, I'm going to ask a question of Fay Holden from the department. From the Department of Health's perspective, what have been some of the key principles guiding the work the department has undertaken in response to the COVID-19 workforce challenge?
Okay, thanks, John. The focus of my work has been around workforce and ensuring that continued access to services and reducing pressures on hospitals. And this has included both identifying and creating surge workforce capacity through identifying workforce that's not currently fully utilised within the health system, such as doctors working restricted hours, students on restricted hours, and other registered health professionals that aren't currently practising. And the initial focus there was to identify and remove or minimise barriers to enable that workforce to commence. And we've worked with ARPA around fast-tracking registrations, considerations of appropriate visa exemptions with Home Affairs, and targeted upskilling, particularly with nurses and critical care nurses. But we have maintained a focus on ensuring our workforce distribution to rural and remote areas is maintained, and the programs support this workforce, that support the workforce, have appropriate flexibilities, and where we streamline processes where possible, such as when we're working with Frank with the RFDS requirements. Many of these have been able to be achieved within our existing programs and frameworks, and they've been able to be adapted pretty quickly without the normal sort of lengthy delays that we have. Key activities in this space have included maintaining our distribution mechanisms, such as the distribution priority area policy, to ensure that workforce remains in rural and remote areas. And this has been a tricky one to hold the ground on, but it's been really important to ensure we don't see that leakage of workforce. Early on we extended the locum tenens from 2 weeks to 12 weeks without needing to request a new Medicare provider number. We've extended the end dates of a number of our 3GA programs, or made automatic extensions for those. We've looked at the GP training arrangements and extended timeframes for their selection processes, and also introduced a second start date for mid next year for the AGPT to allow it for, or account for, extended intern years and increased flexibility to training time. Under our Rural Locum Assistance Program, we've extended the program eligibility there to cover illness, isolation, vacant positions and additional accommodation where the locum's required to isolate during or prior to a placement. But recognising with this locum support that there's still a lot of work going forward in this space, and we're continuing to look at what additional supports, particularly for the longer game around this pandemic. As you said, we haven't needed that surge workforce as readily or in this early phase, but there's a long way to go before we're out of this, and those locum arrangements will be quite critical to ensure we've got continuity of services in rural and remote Australia. We've also had, with our Rural Health Outreach Fund holders, sorry, a bit of a tongue tie there, we've allowed flexibility to adjust service plans and to make workforce support payments in all locations. And we've also introduced some temporary adjustments to the practice incentive program, teaching incentive, to enable teaching to be done via teleconference as well. There's been work with the Department of Education and AHPRA and national boards to develop some national clinical placement principles. And these principles aim to encourage continued clinical training where it's safe to do so, and provide a framework for students to assist in a surge workforce as needed. Longer term, I guess we're very mindful, and I think as you pointed out at the start, that the impact on training now and on workforce is only going to be exacerbated going forward, and needing to understand what that pipeline, or the impact, on that pipeline will be critical. Ahead of COVID, the department was working on a national medical workforce strategy, which we've had some great consultations on, and the consultations ended conveniently at the end of February this year. The themes and the issues discussed throughout the consultation still remain relevant, and perhaps even more so while working through our response to COVID. The department is going to continue to collate information and the feedback that was gathered on our medical workforce strategy, and we'll look to incorporate activities and learnings that are coming out of the COVID response in how we go forward. So we'll start to convene some of the Medical Workforce Reform Advisory Committee. We're going to set up a series of teleconferences to start raising those issues and starting that discussion on getting a clarity of understanding of that longer term impact and how we can consider that.
Thanks, Fay. Really helpful. Can you just give us a bit of an update as to where the National Rural Generalist Pathway is sitting, given the impact of COVID, and where we're at with expediting that program in particular?
Sure, there's been a lot of work around that, and there have been some impacts, like the colleges have made some great progress in the recognition piece about getting the rural generalist qualifications recognised, or the subspecialty. We've continued to roll out the arrangements with the jurisdictions to establish our coordination units. Although jurisdictional capacity has been limited over this time, just in terms of balancing response activities, but there's still been strong engagement. We're just finalising, initial contracts are in place with those coordination units, and we're just undertaking some consultation now with stakeholders just to further refine the role going forward. There are still a number of recommendations outstanding from the Rural Health Commissioner's report on rural generalist training, or the Rural Generalist Pathway, And a lot of those responsibilities sit across Commonwealth and jurisdiction, and so we're looking to establish some forums and with the Rural Health Commissioner to progress consideration of the next tranche of those issues. But in relation to those first ones, which were the initial announcements, were around the recognition of the subspecialty, establishment of coordination units, and an additional 100 RG places with ACRM, which we're working with ACRM at the moment to finalise arrangements for those places as well.
Thanks, Fay. There's a question that's come in online for you, Richard Lunds, and he says, Fay, thanks for what you were doing. Great work. He's saying too that some of him and his colleagues and trainees are having problems with a significant drop-off in patient numbers and income in general practice. And they look after ED after hours with RMOs and or call-ins. They don't have a blanket VMO salary arrangements. They charge the hospital. He's asking any new or current plan for supports in this COVID time as we're exposed to the same risk and also the downtime of exposures. Any response to that?
Sure. So I think we're continuing to monitor that. I don't think, like in terms of, and sorry, I didn't quite catch the first bit in terms of the position, like we're certainly looking at what the impacts are on both AGPT registrars and various positions and where additional supports might be needed either into the program or looking more broadly in terms of what supports go across through the job seeker payment arrangements, which are a broader arrangement to cover off where there is downturn. So we're trying to understand that both from a financial perspective, but also from that clinical training and support perspective as well.
I think Richard, he just put an addendum to his question.
Yep.
I think he's also referencing single employer, new models for rural generalism remuneration and that type of thing. I think that's where he's going sort of post-COVID. What are we looking at in terms of incentivising or appropriately rewarding rural generalist practice? That's the vibe I get. Correct me if I'm wrong, Richard.
No, that's okay. Certainly with that single employer model, and thanks for the reminder of that, because that is another key thing. I think recently we announced a trial that we're looking at in the Murrumbidgee region. While we're making progress in getting arrangements in place for that, there again delays as people were caught up in response activities with being able to progress that trial. That's only a first step at looking at what single employer arrangements might look like under RG, and certainly longer term there's work to be done, and certainly it's been raised in a number of occasions recently that now's a perfect opportunity to try and look at to bring some of those considerations forward. So the department's still working and we'll still work with stakeholders to identify what single employer arrangements may look like and what we might need going forward in that space. But at the moment, what we have committed to is a trial in the Murrumbidgee region, which will hopefully be progressing soon.
Thank you so much, Fay. Like that's really helpful, and I think many of our members and listeners and viewers are going to be happy with those developments within the department and be watching the RG space very closely. Moving on now, I've got a question for George Cerchez from the Department of Health in Tasmania. Obviously, the situation in Northwest Tassie has become a lesson to us all about how quickly COVID can get out of control and how health services need to remain vigilant with infection control. Having to stand down a whole entire workforce must have been a huge decision. Can you give us some insight into that decision and the workforce response which we've seen in Burnie in the current situation, but also the whole concept of having to move large numbers of patients, around the north of Tasmania to, vastly removed hospitals, how that all played out and whether, you think it was successful and where to from here.
Okay, thanks. Thanks for inviting me. I had a very interesting Easter, I must say, up in Burnie. But basically, a little bit of background. Northwest Regional Hospital is 160 beds and has most of the basic surgery and medical units and a cancer centre. The Northwest Private Hospital is adjacent and in fact part of the same building, and it has 48 beds, including a maternity section. So everybody who has babies goes to the private hospital for that obstetric, which the government contracts the private hospital for. Down the road, 3/4 of an hour away, is the famous Mersey Hospital, which John Howard bought for $1 and sold it back to us for an enormous amount of money. So we've got a cluster of hospitals very close together, which became infected with COVID. The Ruby Princess was the original source, 2 patients from the Ruby Princess. And if you look at the demographics and the stats, it was about 7 days before the staff started getting COVID themselves. Now, if you look at the figures, the transmission between staff was very much higher than the transmission between staff and patients. So it says something about their infection control towards patients. But it also says something about normal clinical practice in a hospital. And this is all in a report which we will be distributing the email, the address for, which is the preliminary findings of the outbreak in the Northwest Hospital, which I challenge you all to read, because it's got lots and lots of lessons in it for small hospitals, for surgeries, for anybody who's dealing with the public. Basically, the normal practices within a hospital are not conducive to social distancing. When you think about clinical handovers at the patient's bedside done in a small room, when you think about lunch rooms, when you think about photocopy rooms, pan rooms, and all those things which are normal practice in a hospital setting, including infrastructure and design, you can walk from the private hospital right through to the pathology laboratories, right through to the public hospital in Northwest Regional. So access is one thing you have to think about, and single point of entry is a lesson that was learnt up in Burnie. The other thing is that social distancing is not always taken seriously by staff, as is attending work with an illness. And this was discovered in times of workforce shortage. You feel immense pressure to be on site to help your colleagues. And Northwest Regional always has a workforce shortage across all areas, doctors as well. And I think the big lesson to learn is also that doctors are not immune to COVID. And many of us think we are. And many of the nursing staff behaved as if they were never going to get it, or it was only a mild illness. So the problem was that we had a large number of the nursing and ancillary staff, allied health and doctors infected with COVID. And the only thing to do was to close the hospital completely and do a forensic clean. And you all heard that the Army came in and opened up the emergency department after a forensic clean. And the patients were actually transported to Launceston General, which is 2 hours away, and the Mersey Hospital, which is 3/4 of an hour away. So you can imagine the logistics of that. So what I'd say the lessons are learned from this is that prevention is much better than having to deal with this sort of situation. And Coles was doing a great job in social distancing. And let's just say, had some of those behaviours been followed by the Northwest Regional, and I remember it was early on in the piece, and, you know, doctors and nurses are immune, as you know. Coles was doing a much better job. The shops were doing a better job in social distancing. That's all been fixed, and that's why I commend you to the report of the outbreak, because for small surgeries, for small hospitals, there are many, many lessons in there. Staff worked at multiple sites. So an infected staff who may not know they're infected for 48 hours prior to presenting with any illness, and certainly the asymptomatic, might go between the private hospital, nursing homes, and emergency departments of the two hospitals or the three hospitals. So one of the issues is people who work in different sites you have to give strong consideration to these sorts of issues. And looking at custom of practice of normal behaviour, normal clinical behaviour, and the standards that we have to adhere to, we have to look at them all carefully and say, does this still apply in a COVID environment? And early on, it was not clear that you should stop some of the hospital standards that the Commission for Quality and Safety, such as handover at the patient's bedside. That's standard 6, I think, and it's something that has to happen in a hospital for accreditation. So there's a whole lot of behaviours which you have to really think through in your own surgery, in a small hospital, to make sure that these things don't happen to you. So I commend that report to you. Only read the recommendations. If you're not, it's not a big report, but read the recommendations. There's 14 of them, and they are all to be adopted and publicised widely, I would hope.
Thanks, George. Lots of lessons learned there, and hopefully onwards and upwards for the Northwest. I might move on in the interest of time now to Richard Colbran from the Rural Doctors Network. So Richard, many rural GPs rely on the backup support of the rural workforce agencies as locum agencies, but also for education and support across the country. What have been some of the largest challenges that the RDN has encountered over the last few weeks? We also want to recognise the great work the workforce agencies did, particularly RDN, during the bushfire response and having to back up straight after that from one disaster to another, as much of rural Australia has, from drought to bushfires to pandemic. And how are you surviving, and how's the challenges been for your organisation?
Thanks, John, and thank you as well for the chance to participate tonight. And I hope the information that I can supply tonight is of value, and happy to take any questions during, obviously, or after the session as well. Before I start, as a non-clinician, as a health administrator, I really felt it was important tonight just to acknowledge and say thanks to all the incredible work of those that are dealing on the front line with this issue, and the bushfires and the drought as well. And one of the things that we've seen quite clearly through RDN is a real level of concern and interest in the mental health and wellbeing of our health workforce. And that'll be something that I'll speak a bit more about later on probably as well. But really for this point right now, just to acknowledge the incredible commitment and inspiration that you provide me personally, but also the various teams of health administrators across the country. I think in terms of the challenges, I mean, as you say, we've been dealing basically from the 28th of December in New South Wales in relation to crisis situations, and also probably in the back end of the year with some of the fires in Hunter New England region of New South Wales. I've got off a video conference today with our staff, and I think there's a fatigue setting in for our group of people. We've worked pretty much non-stop for those 5 months. And it's very important to acknowledge the fact that we're talking about natural disaster and emergency response and recovery at the moment across drought, bushfire, and now COVID-19. And a lot of the feedback we're getting from on the ground is that it's very important not to forget the impacts of fire and drought at this time as well. Another thing that's come up while this is talking to the medical workforce, one of the things we have seen is the very serious consequences and impacts on those that are in the non-medical workforces. And that includes all the support staff within primary care and general practice as well. Quite often they're more vulnerable in some respects and not as well to do as some of the medical and more trained professions. And so we're seeing that idea of a whole of team approach as being very important in remote and rural towns, and being able to support each other in a sort of a deliberate way across the whole health workforce team as being something that's very important for the sustainability of each of the services in different towns. One of the critical learnings we faced during the back of the bushfires, and Dr. Penny Burns was very helpful for us in this regard, was finding this very important balance during the emergency period in relation to state or jurisdiction-specific responses during emergency, and then the long play. So in the New South Wales example, which became very real during January, and will come up no doubt in the bushfire inquiries, was pretty much locally based primary healthcare professionals and GPs were closed out of the emergency response as it was directed by the state. That's not a criticism in any way of the way that the New South Wales government responded. In fact, in some respects, I think they'll probably be well celebrated for that. However, in New South Wales, what that meant is we had people who were long-term health professionals and GPs in local communities who weren't able to participate or contribute to the emergency response during that really severe 4 to 5 week period during January. I don't think we've seen the same during COVID-19. However, I think many of us have been very well aware of it and looking hard to push some strong messaging in relation to the role of general practice during emergency. Interestingly, we've had in New South Wales a group formed, which is a very long name, but haven't come up with the acronym just yet. I think it's called something like the Rural New South Wales General Practice and Primary Healthcare Natural Disaster and Emergency Response Group. love a title, but there's 25 to I think 25 or 28 agencies, peak bodies, national, state peak bodies involved in that, which has predominantly been meeting nearly fortnightly since January to discuss the role of general practice and primary healthcare during this emergency response. And I think one of the things that we've learned through that is one that created a great deal of calm within the sector. And if I may just acknowledge RDAA and ACRM as well for their participation and support of that initiative as well. Because I think both for organisations and then also for individuals to know that there was a place to land and we didn't need to compete or fight through the Twitter sphere in terms of who's doing what. And it's been really encouraging to see a great spirit developed in the sector to talk about how as a group and collectively we can combine forces to be stronger. And I think that's been very helpful and important. So this idea of the emergency period versus the long play, the marathon that's going to come, has very much been a part of our thinking and our planning. And I suspect we're talking about 2 years of long play here, not 2 months. I'd suggest at the moment one of the critical things for the sector to be aware of is that we just cannot forget a long-term plan in terms of financial stability and viability for practices, financial stability and sustainability for people's employment of all workforce professions, and then the continuation of what I'd call collaboration in terms of either town-based planning for workforce or sub-regional workforce planning as well. It's very clear to us at the moment, despite many offers of help from various people, either in regions or from out of regions, to come and help and sort of do good and support, that many of the practice owners at the moment and practice staff aren't ready to walk away. You know, there's a job to be done, and they should be credited for that. However, one of the problems that's going to lead to is they will need a break at some point. And this idea of managing the workflow and the breaks across, hundreds of towns across rural and remote New South Wales, and I assume similar across the country, is going to be very important in the coming year to 2 years. And what we can't let happen is that people fall over. So at the moment, we're already seeing some of our clinical friends sort of work themselves to the point of exhaustion. And I think that, I actually don't have the answer to that and probably need further conversation about that, because we don't want to let that happen. And I think that's something that we should all be looking out for and trying to look after our colleagues and friends. I think the idea of creating calmness has been very important. I think that what we're hearing is that there's some very high levels of anxiety and stress within community, obviously, and the patients that people are seeing, but also within the workforce. And just giving people the chance to know that that there is a place to go, a safe place to come back to and bounce off is really helpful. I'd like to think RDN and the other workforce agencies are playing that role, but we're not for everybody. And so I think it is important to encourage people to have that connection point back, whether it's the RDAA or other organisations where they can come and share and talk and take advice. In my world, in the sort of professional world, health administration or professional world, we do debrief and take professional advice. And I think similarly for the business support advice, that will be important for our practice owners and managers as well. The final thing I wanted to mention early on, though, in terms of challenge, was in relation to something Fay mentioned before about the surge workforce. And just as an example, so in New South Wales right now, in partnership with some other organisations, we created what we call the virtual workforce and matching service probably about 8 weeks ago. We've now got nearly 1,200 clinicians that have acknowledged and expressed interest, not to volunteer, but to be paid to deliver telehealth services back into rural and remote New South Wales. Now, it was very important with that, knowing some of the pressures in terms of rural telehealth, that we didn't want people to be beaming live out of a lounge room in Sydney. It needed to be coming in the back through to support the practice. And we're getting questions now already, like how many have you placed? How is this being used? And I guess one of the things that I really just wanted to again call out, this is going to be a 2-year play. The practices yet don't appear to be ready to ask people to come and help. But also there's a really critical need at the moment for adaptability to what telepractice is going to look like. There are some practices that are really struggling and quite understandably to gear up to respond to the telehealth practice model. And obviously there's a lot of discussions to be held around the MBS payments and making sure that there's a strong continuity of care that's provided through telehealth as well. So I think we're in for many months of learning, many months of being able to listen and then being able to represent things back to the department and other key stakeholders. And Fay and her team have been superb to us in the last 6 months in the willingness to listen and trying very hard to adapt to what traditionally are very rigid contracts and giving us the ability to be flexible where we can. And so I do feel just generally overall there's a very strong spirit from local community level all the way through to Canberra at the moment for what we're seeing in response in New South Wales at least.
Thanks, Richard. Really insightful stuff there, and thanks for the hard work you guys have done. And we've really echoed and supported your comments and calls about the long game when it comes to the bushfire and now the COVID response. That we're looking at a very long game in terms of supporting our workforce and our practices in our communities. And we're really grateful for you flagging that and with government and also supporting us yourselves. Now, there's a number of questions coming through, which I'll put to the panel generally, anyone that wants to answer these, specifically around the mobility of the locum workforce. And I know early on in the COVID response, there was a COAG agreement, a national agreement around the ability of locums to cross state borders and to be mobile, but there has been variable sort of compliance with that, with some states having differing rules and regulations. I know this has had some impact on the RFDS and the mobility of some of their staff. Some of the audience are concerned that there hasn't been adherence to 14 days isolation, particularly when talking about doctors parachuting into remote Indigenous communities. So if anyone would like to comment on what the status is with the mobility across state borders and what's currently at play in that space.
Look, I'm happy to jump in with further commentary rather than an answer, really, because I think it's been a very complex environment, and just perhaps add to the questioners and to your comments, John, by saying that we also had situations with overseas trained doctors who were stuck overseas essentially just by the border closures, and so who were essentially locked out of returning to their jobs in remote Australia. So it has been challenging right from the beginning. I think it's fair to say, it would be my impression anyway, that we've seen some of those policies and procedures sort of essentially become clear or clearer as the crisis has progressed. So we've had to make up some of those things as we go along. In some cases, taking a precautionary approach, and in some cases, frankly, probably letting things slip that shouldn't have. The challenge that I think we have is really how we address some of the issues around optimising the care that people need in communities. The care needs of remote communities don't stop just because there's a COVID crisis. and how do you balance then addressing those needs against the very real need to also be providing appropriate protection to those communities where their physical distancing, as well as sadly probably diminishing their health resources, probably increases their natural protections in some ways. So I think it's a bit of a balancing act rather than a perfect answer. From an RFDS perspective, I can certainly say that we've been very respectful of community closures where communities have wished that to be the case, and just absolutely rigorous around additional procedures and protocols that we might need to have in place in order to ensure that we're not vectors of transmission. But I just don't think there are perfect answers on any of this stuff, really.
We've seen a lot of the locum workforce, surge workforce sort of concentrate in states and the workforce move within states rather than interstate. Do any of the other panel members, George or Fay, have any comments about the need for mobility of workforce balanced against of the obvious protections that are designed with state border closures?
Our workforce agency was trying to get some locums into the state, specifically to run the respiratory clinics and those sorts of extra manpower, which was thought to be needed. What happened to the workforce agency was they found that there were sufficient locums within the state who were not leaving the state. So it's really just a matter of putting the word out necessarily, you know, in your own state and seeing what resources you have there. So in the end, we haven't had to bring anybody in yet. Whether that remains so, we have yet to see. But it has a positive benefit by locking down state borders in that those doctors who used to go interstate for locums can no longer do so.
Okay, we've got a few more questions coming through. Did you have a comment on that, Fay?
No, but I can see Richard was keen to add something. I can add a general comment, but I'll let Richard go.
Thanks, mate. I was keen. I was jumping up and down.
I can see.
Sorry, mate. I'm busy trying to navigate the other questions.
I've got your back, Richard.
Thank you, Fay. Thank you. It's a really interesting one, this. So our observation in New South Wales, and again, this is a New South Wales comment, is that the placements are actually proving difficult. I think this is where Georgia was just heading. We've actually got locums who are looking for work in New South Wales. So the out of jurisdiction issue hasn't really come up for us in a day-to-day sense. It's come up on the odd pocket, no doubt, but not commonly. What's been more interesting for us is the credentialing between local health districts, which was a very significant issue trying to move quickly during the bushfires. And I don't think that's been fully resolved yet, although there's been some work to it. So for us within New South Wales, it's actually been the credentialing aspect within the system, which has been, which will be something that we revisit, I think, as we do our learning and reflections of all of this.
Thanks, Richard. There is another question on state borders. It's from Shane Go, and they're saying that previously in South Australia, they did not exempt interstate locums and healthcare workers from the mandatory 14 days quarantine. And that was the agreement I was referring to, that was national, where there was an exemption for 14 days quarantine for most healthcare workers, essential workers moving across state borders. Does anybody know if that's still the case around South Australia, you know, enforcing the strict 14 days quarantine for healthcare workers?
I'm not sure if it is, and I think the movements and restrictions are changing regularly, and so each jurisdiction has them listed on their state or territory health page, and I think it's important just to keep up to date with them. Then I know that's not overly helpful, but I think they did change regularly early on, and they will continue to change, especially as we move forward. So I'm not sure if the South Australia one is still in place though.
Okay, excellent. Well, that pretty much covers off the mobility of locum workforce questions, of which there was a few. The next one is in regard to a rural generalist training. It comes from Michael Clements in North Queensland. Big shout out to you, Michael. Some great work you're doing on COVID education up there, I've seen. But Michael's saying, I work in rural generalist training. There is a potential for a delay in completion of advanced skills training, largely for anaesthetics, but perhaps others due to junior doctor reallocation of terms, plus delays in fellowship completion due exam delays, plus reduction in AGPT sign-up due to movements away from the risk private contracting general practice. Is this a concern? Users, will they cope with the delays or reduction in fellowship? I think that's for you, Fay.
I just missed part of it. You froze when you said, is this a concern? And I just missed that context.
And go on from there. So basically talking about the reduction in AGPT sign-up in general practice. And then basically, so that combined with the other concerns raised earlier, is this a concern that anyone else is working on? And what about end users? Will they cope with the delays or reduction in fellowship numbers?
I think absolutely it's a concern. I think across the board, both in general practice training, but across our whole medical workforce, the impact on their on training programs and has been big, and we're trying to understand that, and we're working with each of the different colleges and with the states and various groups to understand what exactly has been the impact, what supports are needed. Is it just, you know, the exams have been postponed? There's a range of different factors, from university through to specialist colleges, that we're trying to make sure we're across all of the issues and look at what are proportionate responses to the way forward. Some, and it ranges from, you know, deferring exams, and that's extending training time caps, but that in itself has a flow-on effect. So how we can, are there different approaches, different types of, different considerations that can be taken into account in exams? Across the board, there are lots of different things that are being considered. There's not a quick and simple answer that we have now, but yes, very much so. We've been focused on the issues from the start and working across universities and specialist colleges to, one, manage the immediate impact in terms of training positions, but also now very much turning our mind to that longer term training pipeline and the impacts of that.
Thanks, Fay. That was that's really helpful. And look, we have concerns generally about the impact on the pipeline, as I flagged earlier. For me personally, I actually think we've got a golden opportunity for education here. This is a once in 100-year event. A public health crisis like this comes along infrequently. I think we should be seeing it as an opportunity to teach our medical students and our registrars public health as much as anything in disaster medicine. And it's a component of medicine that's real. And I think this is an opportunity, not a threat. And we should be grabbing it by the horns and teaching our students and our junior doctors, you know, pandemic response, essentially, and public health, which is one of the most important disciplines for general practice and for rural doctors in a broader sense. Brings us to the end of our online questions, but I do have another question for you, for the panel, and probably more towards you again, Fay, but a bit about the increasing concerns, the impact of some decisions made in COVID-19 for non-GP specialty training as well, and the impact that'll have on access to care for our communities and our patients. Some of the colleges are extending training time by over 6 months. College of Surgeons is halting its 2021 intake. You know, we've seen, as we've said, many rural clinical schools withdrawing students. You've already touched on it a bit, but is there anything else that you haven't said around the government's response to ensuring that training continues and that we don't have, you know, big holes and leaks in our pipeline, so that we'll have, you know, this problem of deficient workforce at the end of the pandemic?
I think, you know, as I've said, you know, we are very aware of these risks and some of the different varied approaches across the non-GP medical specialties colleges. And we have and will continue to undertake regular discussions with the Council of Presidents of Medical Colleges and with AMC to better understand what those impacts are. I understand that CPMC are continuing to undertake further work in examining the impacts and opportunities as well for reform across all medical specialties. One of the recent considerations, and just probably an opportunity to touch on just to show an example of where we're thinking at, recently through health ministers, there was consideration of the commencement of the 2021 clinical training year. And initially there was concerns about whether that would be able to commence on time for next year, just with the impacts in terms of hospital response activities and the ability to undertake recruitment into that training year. But through working through across jurisdictions and with a number of other stakeholders, we've been able to put advice to health ministers in terms of maintaining that clinical training year, which I think is a great relief across a number of programs and from a workforce perspective. But again, it's something we have to keep an eye on and monitor because the situation may continue to change, but we're constantly looking and trying to take that forward approach to understand those impacts and seeing what we can decide now or different paths we can put in place where needed.
Thanks so much, Fay. Again, it's good to see the department on the front foot with all of this. And, obviously we're very concerned about our workforce going forward for our rural communities. Before we look at closing, we've got 5 minutes on the clock. I'm going to go around the panel and just see if people have got any closing comments or remarks before we finish off. So I'll go to you, George.
I just want to stress that the learnings from the Northwest are applicable to any surgery or any hospital, large or small. And I'd really commend that you read the report. Again, prevention is much better than having to go through the process we've gone through. You know, it raises all sorts of issues like return to work, when do you bring people back? The other issue that's happening in small towns, which the doctors really have to be aware of, is crises bring out the best and the worst in people. And it started with Dr. Higgins and it carried on through to staff in Burnie and in the small towns along the northwest of Tasmania. And that's a victimisation that actually occurs of the staff because they brought COVID into their town. And that's been quite prevalent in some towns up in the northwest. And it's something we have to be really aware of, the mental health impact on our workers who, through no fault of their own, and there was no party, got the virus. And, you know, it's really sad when a community starts ostracising health workers and doctors because they've become infected. So prevention, prevention, prevention. Social distancing, have someone at the front door asking the questions, taking the temperatures. Think about normal work practices and how they should be modified for COVID.
Thanks, George. Very insightful, and we'll definitely have a look at that report. Frank, any last minute comments or wrap up from you?
Yeah, look, just I think a couple of learnings really. One is, and it goes to the comments that I made earlier about our sort of changed relationship, our rapid sort of response to some of this. I don't think we should lose sight of the fact, of course, every death is tragic, and so we can't minimise that, but we ought not lose sight of the fact that our response has been quite remarkable, really, when you think about the realignment that we've managed to achieve in a very short space of time. And I think that should become something that we learn from and celebrate. And the other point I would just finish with is to say, I think we should be doing all the thinking that we can about what the recovery looks like, even though we're not there yet, and even though it might well be, I think you're right to say, a couple of years of dealing with this. I think thinking about the sorts of stimulus measures that we put forward to government to say, look, government, if you invest in these economic stimulus measures, you will get economic stimulus in rural and remote communities, but you will also get more robust and resilient communities come the time, God forbid, of the next pandemic or the next crisis. So I think investing some of our thinking in that future is important.
Couldn't agree more, Frank. Richard.
Thanks, John. Well, a couple of my comments would be that the impact on our health workforce in remote and rural communities is real. So too is the likely financial impact on practice viability, which then will have another impact on workforce sustainability. So all of these issues are real and need to be continued to be talked about on top of the public health and the hospital-based responses. So we'll be looking at that very closely behind the scenes. But I do think it's important to remember that retention of our workforce is going to be critical, not just talking about the future workforce, and that there are initiatives and mechanisms in place through the government and through agencies like the workforce agencies where there is support for our clinicians and our health workforce. And I just encourage people to call out and dive deep into what those are, because at the moment there's all host of different ways we can help and support people. We've just got to find it. It's almost like a person by person approach. So please feel free to call out for any help when you're ready.
Thanks, Richard. Thanks for that. And finally, Fay.
Thanks. And I've probably gone around a few times then as I listened to it thinking, oh no, I was going to make that comment. But I think, and just, I guess, to reiterate, as everyone said, this is it's a long game. And for me, that forward looking about our workforce and our pipeline is really key, but it's not forward looking because it's how we continue to emerge and support our workforce now. As I touched on before, we do have a national medical workforce strategy that we're looking at, and it's not sort of waiting till this is over to work on that. We've learned some really key things now that can incorporate about what's worked well, because there's lots that is working well, what changes for our new normal, what things we want to keep and what things we want to change, especially with some of the rapid development that's been done. Some of it's been great and some of it maybe not as great as we were hoping, but with some tweaks it gives us a new opportunity going forward as well. So I think continuing those discussions and engagements, not waiting to learn the lessons, but trying to build on them and input into them now and work through them, I think is key.
Thanks, Fay. Look, I just want to finish by thanking the whole panel for giving up their time tonight and for their contributions. There's been lots of positive comments already on our question feed on your responses and your commitment. So thank you all. I want to reiterate some of the final comments from our panel members around this being a real opportunity for rural health reform, that, so there can be real investments into rural health now, with extension of telehealth into the future, making sure we fast track workforce programs that are in the pipeline now for rural generalist doctors, nurses and allied health, so we can strengthen our teams. I think we need to take this as an opportunity to be a real impetus for change for rural Australia when it comes to healthcare. So that's sort of our vision, and that's what RDAA will be driving. I want to finish by again thanking all of our frontline workers out there doing the hard yards, particularly in those remote communities, people that have been working long hours and long shifts. We're with you. We want to support you. Make sure you get in contact if you need anything. But thank you again for all of your time and for coming along tonight, and hope to see you again at the next ACRM RDAA COVID webinar. Thanks again for coming, and good night.
Thanks everyone. We'll end the recording now and we'll send everyone out the link in their evaluation. Thank you very much for your time this evening.
Thank you.
Good night.
Thanks everyone.
Thanks, Michelle. Thanks everyone.
My pleasure.
Thanks all.